And start. Okay, all right. It is 10 o'clock for everyone who is here. We have three very unique women speakers, all women this month, and we are going to start off with Briana Hagen. She is our neighbor in Canada, and she is going to let us know all things Canada in the mental health department, resources and et cetera like that. So, Ms. Briana, we'll let you go ahead and start sharing your screen, and then whenever you're ready, you just take it away.
Okay, how's that? Are you seeing my slides? Perfect. Okay, well, thank you so much for having me. I am so excited to be joining you from the north. I heard a rumor that I may be one of the first Canadians to share space with you all, so I'm very excited to be here and share what we've been working on and kind of where we're headed in the next little while. So yeah, as you mentioned, I'm Briana. I am a researcher over at the University of Guelph, which is right near Toronto, Ontario. And I'm physically located in the prairies in Manitoba, so smack dab in the middle of Canada. And, you know, I had the opportunity to connect with some of the folks from AgriSafe when I was over at the ISASH conference, and we talked about some of the similarities and differences that we had across the border, and thought it would be a good learning experience to talk about what is the state of mental health in farming in Canada and some of the programming that we've been using and developing. So for those of you that don't know, similarly to the US, Canadian farmers are experiencing increased prevalences of depression, anxiety, burnout, and stress. Canadian farmers have significantly lower resilience compared to other occupations, and they are less likely to seek help for mental health supports. As we know, farmers have an increased risk of suicide, and they're uniquely experiencing this climate crisis that we're all in, and having increased agricultural emergencies and all these other factors that can really significantly impact mental health that we don't really understand deeply. So one of the ways we wanted to understand was to start doing some baseline statistics around some of these mental health outcomes, which hadn't been done in Canada up until 2015. So back in 2015, we did our original survey, and then we decided to make it a cycle, 2016, and make it a 5-year cycle. So we just collected new data again. We did another cross-sectional study online across the nation for any farmers that wanted to participate, using validated mental health measurement tools to see if the prevalences of some of these mental health outcomes had changed. Now, we did do this study in February to May 2021. So kind of we have to remember that COVID was also happening at that time. So I want to make sure that I made note of that. But we did have a great response to our survey. We used, as I mentioned, validated tools to look out at stress, burnout, anxiety, depression, suicide, alcohol use, alcohol and drug use, and coping. So some of the results that I wanted to share with you. So we had a total of just under 1,200 people who participated in the survey. We offered it both in English and in French because we are a bilingual country. We had about 37% women, 57% men, and 6% who didn't provide a gender. You can see here the breakdown. Oh, you can't see my clicker, but on the bottom part of that slide is the breakdown by province. So when we're looking at the bottom bar, that's the response to our Canadian census data, Mental Health Research Canada's data on where farmers are located and what percentage, and then our survey is above, showing what our representation per province was. So you can see we had a bit of an overrepresentation in Ontario and Quebec in our sample. And then when we looked at age, I think that's on my next slide too. Oh, it was on the other slide, but sorry, I'm going to go back for 1 sec. So when we looked at age, most of the folks who participated in our survey were over the age of 45. So just a little bit more on the demographics. 20% of folks who participated were first generation farmers. So 80% had been on the farm for at least 2 generations or more. And almost 85% of our participants were married. Over half of our survey population had completed a college or a university degree, and pretty much everybody was white. So now kind of diving into some of the results here, we have some really cool, beautiful graphics. We try really hard in our lab to make sure that our data can be presented to academic groups, farmer meetings. We want to make sure that people can engage with it. And we have a wonderful student named Shelley Thompson, who is a farmer herself and has such a creative mind for this type of thing. So I just wanted to acknowledge that she made these beautiful graphics for us. So in terms of resilience, women had significantly lower resilience scores than men in our 2021 population. The resilience score for the overall sample and the gender specific norms for men and women farmers were all significantly lower than for the normative data. When it came to anxiety, the scores were categorized, as you can see here, to provide symptom severity classifications, which is how that scale is used, from no anxiety, mild anxiety, moderate, severe. So approximately half of our participants were classified as having no or minimal anxiety. Almost 30%, 13%, and 6% of participants were classified with mild, moderate, and severe anxiety. Women fared worse than men in our study. And the overall 2021 study population, as well as the gender specific norms for men and women, were all significantly higher than the respective scores for normative data. This was also true for depression. We used the PHQ-9 to measure depression, and the same thing from mild all the way to severe. Approximately half of our participants had scores indicating no or minimal depression, but 30% were classified as likely to have mild depression, 12 as moderate, and almost 7 as moderately severe, and almost 3 as severe. Again, here, women who farm fared worse than men, and the overall study population and gender specific norms were significantly higher. When it came to stress, we measured stress using the PSS-10, and they were categorized according to the classifications of that scale, so low, moderate, and high. Approximately 24% of the participating farmers had scores in the low category, so the majority, or over 75%, were classified as experiencing moderate or high perceived stress. Women, again, fared worse than men here, significantly. And the score for the overall study population, as well as gender-specific norms, were all significantly higher than the general population. When it came to burnout, there are 3 subscales that were used to measure burnout: emotional exhaustion, cynicism, and professional efficacy. Women had significantly higher exhaustion scores than men, and there were no other statistically significant differences between genders. Exhaustion, cynicism, and professional efficacy scores were significantly higher than normative general population scores, which is very interesting, especially when thinking about professional efficacy. So normally folks who are burnt out have high scores in exhaustion and cynicism and low scores in professional efficacy, or their belief in their ability to do their job well. Here, farmers were still scoring as burnt out because of the high scores in exhaustion and cynicism, but they still scored highly with professional efficacy, which was a little bit unexpected. So regardless of the high cynicism and exhaustion, they still felt that they could do their job well and they were good at doing their job, which is kind of a unique thing. When it came to suicide, approximately 17% of participants reported having seriously considered suicide. and 1 in 5 participants reported that they felt their life was not worth living within the last 12 months. And approximately 1.5% of our study population reported having attempted suicide since they started farming. And in all of these instances, women had significantly higher reports of suicidality than men. Another thing that was interesting in our study was looking at coping methods. So more than half of the participants reported feeling that they generally got enough sleep, which is interesting because that is not what we would hear in our day-to-day life from folks that I've talked to who farm. And then, almost half said that they did not. Significantly more men reported receiving adequate sleep than women. Even still, farmers use sleeping, avoiding others, eating behaviors, self-blame, and drinking significantly more than the general population. Men had significantly higher audit scores than women, looking at alcohol use compared to normative data. Audit scores for the overall sample and for women were significantly higher than general population normative data. So that's kind of a really brief overview of where things are at in Canada. I know that I'm already going close to my time, but I wanted to talk about just a quick 2 things that we've been working on in terms of programming. So we kind of have a bit of a dreary, this is what's happening, and the prevalences are not great. Some of the things we are doing to tackle that include looking at improving mental health literacy, which was a direct call to action from farmers themselves. So we developed a mental health literacy training that was specifically for farmers called In the Know. And that was developed and piloted as a part of my PhD work. So we developed it as a 4-hour in-person small group lecture and discussion-based training that then very quickly had to pivot to go online throughout the pandemic. But basically we wanted to know, does it improve confidence and knowledge, attitudes, and beliefs around mental health? And what we found in our evaluation was that it did significantly increase knowledge around mental health, confidence in recognizing mental health struggles in others and themselves, confidence in speaking about mental health with others, and confidence in helping someone who could be struggling with mental health. And all of the participants who participated in our evaluation process, which is about 100, said that they would recommend In the Know to another farmer, providing it that farm credibility that some of the other mental health literacy trainings lacked. And now this program has been pushed out to run almost all the way across Canada. And we have trained over 1,000 people using In the Know, which was very exciting. And then the other piece of work that came from some of this data was developing an emergency response model for mental health during an agricultural crisis. And this was a big gap that this model helped to fill as a way to engage industry and get them more familiar with mental health and have some tools for them to prepare to respond to some of the agricultural crises through a mental health lens. So it has preventative, interventional, and recovery efforts that are all focused on ensuring that farmers, farm workers' mental health is on the checklist when we're, responding to a disease outbreak or a depopulation or a barn fire, any kind of agricultural crises that could occur. We wanted to make sure that mental health is also top of mind. So that was kind of like a real quick and dirty talk about what we're working on right now. We also have a few new programs that are being developed right now that I'd love to talk about more at another date. But that was just a really broad overview of kind of where we're at and where we're going. So thank you for having me. And if I don't know if we do any questions now, but if
yes, this has been very interesting. We have lots of questions for you. Briana has about 6 minutes before she has to leave for another meeting. So we're going to try to get these in. The first one, Adam has 2 questions. He said, on your resiliency slide, what makes up the resiliency score?
So we used the CD risk, which is a validated tool to measure resilience. We used the CD risk 10. So there were 10 items that you then score according to the manual to get a resilience score out of 100.
Okay. And then he also wanted to know, did you collect any data about the size of farm, type of farm, maybe rent versus owned ground, gross
Yes.
revenue, debt, all the
Yes.
above?
Yes, we did. I didn't get into any of that just because I wanted to be able to share some of the more broad mental health results, but yes. So in some of the modeling that we're doing, looking at these outcomes, so looking at risk and protective factors, we take those into account.
Okay.
Briana, would you be willing to share with me your study? Because you might save me a lot of work, because I would like to kind of do something similar here in South Carolina, here in the States. And so the other one that, were you able to capture not only gross revenue, but also overall household income to be able to capture if there's any off-farm income coming in, and then correlate that with the depression and potential for suicide, etc.?
Yes. So with the caveat that these were self-reported. So we did collect household income as well.
All right, fantastic. I would like to see everything that you use, and so I can figure out what I need to do down here. So I will, if I can have that, that moves me 2 steps forward, and I'm going to then grab a graduate student to start.
Yeah, for sure. If you wanted to follow up by email, I would be happy to share.
Yeah,
I appreciate that.
I think Rebecca had the same question as Adam, because she loves your information in the slides, so she would like to see more as well.
Cool.
So once Brianna's done with questions, we'll go ahead and have her contact information in the chat. And then also your project that you shared, if there's a website or something that we could post in the chat as well, we would love to do that.
Mm-hmm.
Amanda has a question. She said, was the stress coping from a validated assessment or additional questions? Same thing. She would be very interested in replicating your study.
Yep. We used validated scales for everything.
Awesome. Jennifer asked, can you speak a bit more about the training mentioned, or emailing afterwards if it's too much?
The training of In the Know?
Is that what you meant, Jennifer? Yes.
Yes. So I can also email you the paper that outlines the training and link you to the website. If that's helpful, because I could talk all day about it, and I know that there are other folks.
I can send you an email and then you can just respond with that. That would be great. Thank you.
Perfect.
That's wonderful. I love this. Meg says, in our experience, chronic stress can be as challenging as a crisis, and she loves your graphics on your slide.
Oh, thank you. I will tell Shelley about that, because she did work quite hard on them. And yes, totally. Stress is something that people really underestimate sometimes, and sometimes overuse the word when really what they're experiencing might even be a mental health, a large mental health concern, like a diagnosable anxiety.
Okay, so we have a lot of people asking to share the study, like they are loving it.
Yay!
Since I can bulk email, is there a way, is that appropriate for you to send that to me to be shared out to everyone?
I don't see why not. I will just double check with our lab to make sure. I know we're also in the process right now. It's under review for publication. So hopefully that publication would be an excellent way to see all of the results, including the COVID adjusted stuff. But for the methods and what we used, I'm happy to share that like immediately.
That's wonderful. Sean asked, have you ever looked into training farmers or any kind of ag-related role in the living works training, like Safe Talk?
Yeah, so we did. We actually we did some trial sessions or pilot sessions using some of those, the assist and mental health first aid. And what we found was, while it was useful, there were barriers to taking it and some non-relatability of the materials for farmers. They felt it was very urban-centric examples and not as accessible to them. So we decided to kind of revamp and create something that was ag-specific that all the materials were really relatable for folks. That was the reason.
All right. Well, you were a hit, Briana.
I'm so glad.
Before you leave, can you put your contact information in there, and then also the link to your project? And then once you get everything okayed through your work, you know, if it is okay to send out that publication, I can go ahead and bulk email everyone, and I'll make a note of that right now, because they are loving this.
Awesome. And then this is a website where you can see kind of the stuff and the materials, but not the specific methods, but I can send that.
Okay. All right, that's fantastic. All right, Miss Amanda, we're gonna go ahead and have you get ready to share. Amanda has a very interesting project that is, I don't even know if it's public yet. I know it was just getting off the ground about telehealth. So we go ahead and let her start sharing her screen, and we'll go ahead and listen to her project.
Good morning, everyone. First of all, thanks so much for having me. I so appreciate the invitation from Carrie, and thank you to Lucy Polly from Wyoming Department of Agriculture for the connection. And I'm very excited to share. Oops, let's see if I can share my screen properly first. That seems important. Okay. I'm excited to share our grant project with you. So my name is Amanda. I am a recently promoted, so now I'm an associate professor at the University of Wyoming. Breaking news. So I am a coordinator for a master's in counseling program in Casper, Wyoming. So I'm based in Wyoming. We have a lot of farming and ranching communities here. And mental health is my background. So I'm a licensed professional counselor. I actually work in private practice outside of my work with the university here in Wyoming. Do a lot of telehealth work with folks in more rural communities around our state. And my general research agenda really focuses on healthcare equity and access issues. So looking at underserved populations and how do we get resources and mental health supports where they need to go, which I know is a big part of the AgriStress mission as well, is to help farming communities get access to mental health resources that they need. So like many healthcare fields, as COVID-19 came into the picture, we saw this huge increase in telehealth access to different kinds of mental health supports. So not just in mental health, but in physical health, in many healthcare arenas, we saw this explosion of people starting to use telehealth for the first time, both as patients and clients and as providers. And that really shifted the landscape of the healthcare fields. And I think it shifted in a way that's going to remain pretty well permanent. A lot of states are passing legislation now that provide telehealth parity, which means that insurance companies have to reimburse for telehealth services at the same rate as in-person services, which prior was a barrier. There also were not adequate billing codes for providers to bill for telehealth care, which was rectified in COVID because the insurance companies had to come up with billing codes. So good things coming out of necessity, I suppose. And those billing codes also are not going anywhere. This week on the national scope, and again, this is more US based. I appreciate the previous conversation related to Canada, and that study was way cool. I want to know about it too. But actually nationally, there was some legislation that just passed the House of Representatives that preserves some of the expansion of things like HIPAA regulations for telehealth access through 2024. That goes to the Senate, and we wait to see what happens with that. There are also several professional licensing compacts in social work, counseling, psychology, and mental health related fields that will open a lot of possibilities for people to work across state lines where that was a previous barrier in the way of state licensure. So all of this put together means there's a lot of new, exciting, innovative ways that we can use telehealth to get mental health care where it's needed the most. But part of my research is looking at who's getting left out. So telehealth is wonderful. But if you live in a rural farming community and you don't have good broadband access, or you don't know where to find providers, or home is not a safe place for you to connect with providers because there's a lot of stigma and it's not okay to ask for help, the traditional telehealth model is not going to work for you. You're going to get left out of the picture. And that's where the PATHS program hopes to come in and address that need. So PATHS is a grant-funded program that I developed. We've been working on it for almost a year now. And it's my stab at being clever. So PATH stands for Public Access Telehealth Spaces. And I'm going to walk you through just a broad, like 50,000 foot view of the project, and then very happy to answer questions or connect to talk more about how we're doing this and how we're implementing this in different places. So the PATHS program really was born from a mental health provider, which was me, trying to figure out what are spaces that feel very stigma-free, very welcoming, and that community members are already accessing. So how can we bring telehealth to the community instead of trying to get the community to come to the providers, right? Because we know, especially with agricultural communities, that model doesn't work. So PATHS, we really started looking at what kind of community spaces feel safe. And oftentimes the answer is public libraries, which is where we started. But we're also now working on expanding into university extension offices that do a lot of work with agricultural communities as well. And so what we are doing is we're creating an implementation model to create safe and secure telehealth access spaces and wellness resources in these community areas where people are already spending time and associate these as safe spaces for them. So we created an infrastructure here in Wyoming. We're doing a statewide pilot project right now to connect via telehealth networks, providers, and resources for continuity of care for different communities of need. And so in that way, we strive to create an innovative model for integrating healthcare resources and making them equitable and accessible to everyone. Right now, this is just a statewide pilot in Wyoming. I'm not going to pretend like we're the first people to try to do telehealth in public libraries, but we are the first statewide pilot program of this nature. And I have worked with and collaborated with other libraries in the U.S., who have tried to do this to learn from how they implemented things and then work to improve the model so that it's really transferable and usable anywhere in the U.S. or really anywhere, I guess, in the world. I'm going to go present in Europe about this in October, so we'll see how that goes. So essentially our goals are three things: addressing healthcare equity by creating telehealth originating sites, which just means publicly accessible access spaces for community members to access healthcare in stigma-free environments. And then on the provider side of things, creating an inclusive provider network to coordinate care, create better communications between organizations that are doing really cool work, and making sure there's a lot of awareness of resources for community members. So we have really great resources. People are doing great things. We're still not getting them to the community members somehow. So we're trying to build a more integrated care network across the state so that folks via telehealth can access maybe specialty services, or there are a lot of situations where in mental health, it's better to not have someone local. Maybe I don't want to talk to my local provider because I know them. I run into them everywhere. If I go talk to them, everyone's going to know about it, even if I do have this confidentiality thing. I don't trust that. So maybe talking to someone from a different community is actually a better fit, and telehealth makes that possible. And then we're supporting library partners and guiding implementation of creating telehealth in library spaces and bringing them into this partner network so that we create this, imagine it like a web or like a safety net, if you will, of resources across the state, especially for individuals in more energy-based industries and agricultural industries who might move a lot or need to travel a lot. You can go to your local library space, ideally just about anywhere you are in the state, and still be able to access healthcare in the same way as if you were at home. So that's what we're trying to do. This is what's guiding our implementation and evaluation process. So the CDC developed this implementation guideline for programs that are addressing health disparities. And we know that in farming and agricultural communities, health disparities are huge, right? So I won't go through each of these, but these were our guiding principles in putting together the model that we're using to expand access to telehealth in the communities. So our goal, and my goal, is to not just buy cool equipment and then leave it somewhere in a corner to not get used. I really want to integrate all of these steps to make sure that there's a lot of visibility, there's a lot of public awareness, there's a lot of connection to providers, and there's ongoing support for our community spaces that are integrating telehealth into what they do. So we really focus on three areas. There's this education component. So we're working with local departments of health to offer things like Healthy You programming and health and nutrition programming, and then doing things that feel really relevant to those communities. That's where things like the Farm Safe program might be really great to integrate into what we're doing. We're also doing provider education on specialty services. So I know I've invited Carrie to come to our Project Echo network to talk about working with agriculture and farmer communities. And this is really geared towards physical and mental health professionals who work in mental health spaces. We also have that integrated telehealth providers network here in Wyoming. A lot of states have similar networks, or we're working with those states to develop those networks. We're working on prevention, so using things like university resources to offer free screening and referral information to any patron in the library who wants to use them. Building health information centers. We're doing suicide prevention training using QPR with all library staff, so they feel ready to support any patron who comes in to use those healthcare spaces. And then there's the intervention part. So we're using grant funds to actually purchase and install HIPAA secure, ADA compliant telehealth access booths and all the equipment needed for people to access healthcare in a safe and secure way. I know I'm talking really fast because they don't have a lot of time. So currently, here's where we are. We have 3 funded sites that are going live, hopefully by the end of this year. Those are in Cody, Casper, and Rock Springs here in Wyoming, and those are in Park, Natrona, and Sweetwater counties. Currently working on about $3 million worth of grant applications. Those would expand into hopefully 8 to 10 sites over the next 2 years in our state. Currently, I have commitments from libraries in Cheyenne, Sheridan, Gillette, and Wheatland. We're also having conversations with folks in the Washakie area, which is on our Indigenous reservation here in the state, and also talking with folks in Torrington and Buffalo about possibilities there. We're trying to kind of strategically, geographically hit most areas of the state, and also looking at libraries that already have pretty decent infrastructure to implement this, and then looking at how to work with more rural communities that don't have as much space or don't have as many staffing resources, and figuring out how to adapt the model for those spaces as well. This is a picture of what the booths look like. So they're pretty neat. They're essentially tricked out, repurposed cubicles. They're self-cleaning. They have a UV system that does a 3-minute self-sanitizing in between each person who uses them. They have air circulation. They actually have these really cool skylights. So there's natural light in there. It doesn't feel like you're just sitting in a cave. And actually we are upgrading the insides to be this really nice light wood grain, very inviting feel. And then we're doing custom graphics on the outside for the logo of our project, the 988 suicide, the new 988 suicide lifeline number, and then any sponsoring or grant funding agencies, so they get their logo on the outside. We are being careful to not put any provider logoing on the outside because we don't want this to seem like it belongs to any one care provider. It really belongs to the community. I also currently am talking with the state libraries in Idaho, and they are potentially also joining our network because they got a big grant to do something similar. And so we're talking about ways to collaborate and work together between the states of Idaho and Wyoming. Also having some conversations in Arizona, and would love to talk with other states who are interested in doing a broader implementation of this as well. So where are we going with all of this? In like 2 minutes or less, right? So right now, grant writing is my whole entire life to fund this thing. The nice thing is most of the costs are up front in purchasing the equipment. Those booths are built to last 10 to 15 years. And those are the most expensive part of the project. So that initial grant funding kind of covers that implementation. And then we work with the libraries or the extension sites to do ongoing like replacing of computer equipment and those kinds of things as needed. So sustainability, the cost isn't that bad. It's mostly upfront. So we're doing a lot of grant writing to get that, working with the state to get a hold of some ARPA funds to cover some of that implementation too. Doing provider training and telehealth for vulnerable populations, as I talked about. Would love to create some broader partnerships for interstate networks as providers are starting to work across state lines more often. Having a broader integrated care network for our communities makes sense too. We're also exploring other options for originating sites. So we just secured a partnership with our university extension here at University of Wyoming. So we're going to look at putting these resources in our extension offices around the state. we're also talking to local jails about some possibilities of doing that too, for things like addictions assessments and coordination of care when people are incarcerated. And then we're getting ready to launch our website, publish our implementation model, and develop a readiness assessment. So if you're interested in doing this in a site in your community, we're creating an assessment that you can use to determine if there's appropriate infrastructure. Quick shout out to all of our current partners who are wonderful supports, and I could not do this without them. It was me in my office and a library director who wanted to do something cool, and all of these people gave us resources and support to get us where we are now. So I would be remiss if I didn't take a minute to say thank you to them. And this is me. So would love to collaborate or answer questions. I'm the project director for PAVS, so more than welcome to reach out to me. And just also acknowledging Babs Wiseman, who's my assistant director on this project, and is a psychologist in our state who just does this as a volunteer in her spare time because she believes in it. And I cannot say thank you enough for that too. Woo!
Wonderful.
I think I did 1 extra minute, Carrie.
Yeah, that's quite all right. When I heard you talk about this idea, I was immediately intrigued and said, we've got to get her on. I've never heard of anything like this before. And one of the things that we hear from our farmers and ranchers that I like being able to go into the library is that most of the time rural broadband is not good. So trying to do telehealth at home sometimes just isn't going to work. But if you're able to go into town where there is significant broadband, boy, that really helps them. And they also have the privacy that they desire as well. So, so Adam and I had the same question. Is the booth soundproof, or do you have it in an area where like the public can't go by, you know, as you're doing telehealth?
It's sound reducing. So it was important to the librarians that they knew when someone was in there, and they'll know anyway, because they're actually, the equipment is kept secure and you have to schedule an appointment to use the booth. That way, if you have a healthcare appointment, you know it's available at the time that you need it. So we're working with each library site. They actually already have meeting scheduling systems in most of these libraries. So we're just adding this as a meeting space option. You would check in with the circulation desk, they'd let you into the booth, you'd have your appointment. So they're sound reducing in the same way that a lot of physician or mental health offices are. There's like a white noise machine so that you can't hear what someone is saying. There's also frosted glass so you can't see inside of the booth for privacy's sake. And then we actually are working on creating some kits that can be checked out in addition that have basic telemetry devices and remote patient monitoring devices. So actually a physician could get like blood pressure, heart rate, like basics that they would need for a physical health appointment as well.
Yeah, I love this idea. So Joy wants to know, what is the cost of the booth? I know you said they're recycled, which I'm a big recycler, so I love that. So what is the cost associated with that project?
Yeah, so there's quite a bit of revamping, and they're custom built with we're working with a particular vendor out of Boulder, Colorado. I know there are a couple of other comparable companies that do similar things. So a full implementation runs about $30,000 a space, and that includes not just the booth, which runs about $24,000 for the custom build and the graphics wrap on the outside. That also includes the computer equipment, the microphones, the equipment that is at the appropriate specifications to do a good telehealth visit. And then also some money for like brochures, bookmarks, like things that can publicize and let, like, we distribute those with providers in the area to let them know that they can refer their clients to use that space, some supplemental marketing and staffing support for training. So 30,000 is like a full implementation that includes like a good public awareness campaign in the local community, work with providers, staff training, etc. But the booth itself runs about 24,000. I have a budget. I'm very happy to share it with you if that's useful.
Wonderful. Sarah has a question. Is this only mental health, or is it physical health as well? Because you did mention blood pressure. And then she also said, you mentioned QPR training for the librarians. Do they receive any other training on resources that are available locally?
Good questions. So can be mental health or physical health. We've had a lot of conversations with providers, and having a mental health provider shift to telehealth is just a little bit of a simpler transition versus a physical health provider. And right now our target is working with providers that are already using telehealth. So they're already working with clients who access healthcare from home. So a lot of these for physical health are like follow-ups with specialty providers, as opposed to a full-on primary care, which involves needing a bit more equipment. The next phase of our project is working with providers that aren't currently using telehealth to see, essentially a needs assessment of what do you need to feel comfortable and to get adequate training to expand what you do online, so we can get it into these communities that maybe don't have that specialty care and maybe don't have that primary care option. I'm also talking with the VA about some ways to expand and working with veterans in that area as well. So it's really both. And Wyoming Center on Aging has a grant through the American Heart Association to look at remote diabetes monitoring and remote being able to take heart rates and things. So they're actually putting together the kits, and they're just working with us to put them into the library spaces where we're doing the booths. And then we're going to pilot test what that looks like and then tweak the plan from there. So that's a little bit of a work in progress on the physical health side. Mental health is, again, a bit of an easier lift. We do the QPR training. I found out librarians don't actually get a whole lot of support or training in mental health. They usually have staff protocols around physical health emergencies. So like if someone's having a heart attack, there's generally a protocol for that, but there really wasn't much to support them in the way of mental health emergencies or crises. So the QPR training kind of fit that need pretty well. And we're working with local suicide prevention specialists to provide that training in each county. And then they're actually highlighting the use of our booths and any tabling that they do at community events. Hopefully that
sounds like you are on top of it.
I'm trying to be.
Yeah. So you shared your email in the chat, but is there a like a website where you have this project listed that you can also post?
So we're designing that now.
Okay.
You're kind of like, you heard.
I know you're very new.
A little bit. Yeah, it's very new. And we should be launching the website. So we'll have two websites. We'll have a website about the project itself that should be launching end of August. And then we actually have a partnership with the state library. So like in every state, there's individual libraries, and then there's a state library system. And they get a lot of federal funding for coordinating between libraries. So I'm working with them. I'm actually launching a website under the state library system with an interactive map where community members can go find their resource closest to them, and then links to schedule appointments online in one place that's really easy to find. So we'll have two websites going live at the end of August. One for the community to be able to locate their nearest resource when those go live later this year, and then one on the project itself.
Well, we will have to have you back in a year and see how much.
Oh my gosh, I would love to.
Yeah. So we'll just, so that we're staying on time, there is another question in the chat. If you can answer that within the chat, and then
Absolutely.
we'll let Faye go ahead and get started so we don't run her out of time. Thank you so much, Amanda.
Thank you so much.
All right, Miss Faye, we'll let you share anytime.
All right, I'll see if this works. Do you guys see that okay?
I'm still seeing your photo or your video, I'm sorry.
Okay, let's try this again.
There we go.
Perfect, okay. Hi, everyone. Thank you for having me today. My name is Faye McGuire, and I have my doctorate in occupational therapy, as well as a background in public health and psychology. I currently work for Texas A&M AgriLife Extension for the Texas AgrAbility project and the Battleground to Breaking Ground program. And both of these projects are grant funded through various USDA programs. So today I just want to talk a little bit about some of the resources that we offer for our beginning farmers and ranchers and our veteran population. So who we serve all beginning farmers and ranchers through our grant programs, but we have a heavy focus on serving the veteran population. And I started with the project about 1.5 years ago as a grad student. And I had an interest in looking at the transition supports for military veterans as they were sort of making that leap from active duty to being a veteran back in the civilian population. And I had a strong interest in agriculture. So when I found the Battleground program, I thought it was wonderful that that's what they did. They helped veterans get into agriculture. And as part of this, I was looking at their mental health concerns as they were transitioning, since many of our service members sort of feel lost and feel like they have a lack of purpose as they're transitioning out of the service. And as part of this research, I interviewed a lot of our clients, and over again, I heard that they really liked going into agriculture because they found it therapeutic and it helped them reestablish a sense of community. They felt like they were serving their country again and providing for their community as they were raising crops and livestock. So one of the things that I found kind of interesting in doing this research is that when we look at our veteran population, they already have a high rate of mental health concerns. Many of them have PTSD, they suffer with anxiety or depression. And then we introduce them to farming and ranching, which is wonderful, but that's another population that has a very high rate of mental health concerns. So I was interested in kind of seeing how the gap was being bridged, so that we were able to use the agriculture in a therapeutic way, but that we were also addressing the mental health concerns that both populations had. So one of the things that we do for our clients in both of our programs, when they come in, they do intake forms. And one of the forms that they fill out is a modified McGill quality of life survey. And originally we had used these surveys just as a way of seeing progress and satisfaction from start of our programs to the end of our programs. And when I came in as an intern, one of my first tasks was downloading these forms and uploading them to a file or a shared drive so that we would have them to see that progress over the course of the year, or for some of our clients who work with them closer to 2 years. And as I was going through them, making sure they were complete, I started to notice that many of our clients were rating themselves pretty high on the depression and anxiety questions. And when I started noticing that, I kind of took it upon myself to say, okay, I'm going to start screening our clients as they come in and start offering them mental health resources as soon as we identify that they might have a need for this. And so with that, I started reaching out to the clients directly upon getting their intake forms. So one of the resources we were already offering our clients is something called Vet Advisor. And as part of our grant program, they receive free visits. We had been doing 6. Right now, I think we're at 3, but if they have a need for more visits, we absolutely provide those for them. But we weren't having them connect with Vet Advisor until they were in the program. So while it was a great resource, it sometimes was weeks until the intake forms to when we were actually able to connect with somebody through Vet Advisor. So I kind of switched that process when I started doing these screenings and started reaching out to the participants right away, providing email resources to them. And one of the reasons that we chose email is that there is that stigma surrounding mental health. And a lot of participants, especially our veteran populations, they don't want to talk about it. So one of the things I found is even in emailing them, a lot of them would say, oh, I'm actually fine. I made myself seem like worse than I actually am. And I think part of the reason for that is when they were filling out these intake forms and uploading them, they're uploading them to a course. They weren't being directly emailed to a person. So I think they were being a little bit more honest on those forms since they didn't have to have that human interaction. And then when I initiate the email, it starts that interaction where they're like, whoa, I'm actually okay. And they start to backpedal. But I like the email because I send them a variety of resources that they can then follow up on their own, and they don't have to say anything to me. So I think that helps because it gives them something they can reference back for a later time or something that they can proceed ahead with without having to outwardly say like, yes, I need help. And I think that's one of the biggest challenges that both our veteran population and farmer and rancher community have is that asking for help. So like I said, we have Vet Advisor that we already offer them. And Vet Advisor is pretty cool from an OT standpoint, I think, because it's a holistic service. So in addition to addressing mental health concerns, it also helps them with financial resources, stress management, physical health. And I think that's really important because oftentimes we look at mental health kind of in a vacuum, but it's not. So everything that goes on in a person's life needs to be addressed because they are impacting their mental health, whether they directly realize that or not. And then I went out and found a few more resources that our participants could connect with a little bit more readily. So 2 of those are called Headstrong and Give an Hour. And both of those are for veterans specifically. And what they do is they connect the veterans for free with a mental health counselor. And Give an Hour works to try to connect individuals with a counselor that's in their area. So if they want to meet with somebody in person, they can. But if they don't, both of these offer virtual services as well. And then another resource that I like to share with our participants is the Wounded Warrior Project. And they have quite a few different programs. 2 of the ones I have listed are Project Odyssey and the Warrior Care Network, but they have other programs as well. And another reason that I like this is they have clinical and non-clinical resources. So it could be something like a phone call where someone's checking in with them once a week, once a month. They can meet with peers to have that mental health support network. And there's also that support for caregivers because it's oftentimes not just the mental health of the veteran involved, but also that they're caregivers who are dealing with the struggles that the veteran themselves is having. And then 2 other resources that I like to share with our veterans in Texas specifically is TexVets. And that is a website that has a whole bunch of resources. Again, it's a holistic approach where it offers financial coaching, there's legal services, and they're all vetted organizations that are known to have a track record of working with veterans to help them get the services they need. And then another website that's very similar is the National Resource Directory. And similar to TexVets, it is a vetted group in different categories, again, such as financial services, legal services, mental health services, that have all been verified that they provide decent services. But I like that one because it's national and it's not just focused on veterans. So while we have a focus on veterans, we do have some beginning farmers and ranchers that come to us that can't benefit from veteran services. And then for our clients that are in more acute distress, I like to recommend, recently I learned about the AgriStress helpline, which is great since that's a 24-hour support and it's available to our clients, whether or not they're veterans or not. And then there's also the Veterans Crisis Line, and that's similar to the AgriStress helpline in the fact that it's 24-hour support. It connects them with a mental health counselor. They can call, they can text, they can chat online. And one thing that I really like is that it's not just for the veteran themselves, but anyone who's involved in the support, our care team for veterans. So we had one individual who was in an acute crisis, and I didn't really know what we could offer him when I was new to the project. So I reached out to them and they walked me through the different resources that I could offer this individual, just that existed beyond their helpline. So those are usually the resources that I will suggest to participants. If we think they are in an acute distress situation, we will try to reach them by phone to offer those services in more than just an email. And in certain cases, we have reached out to loved ones. It's always a delicate situation bringing loved ones in. But if we think that someone's at risk of hurting themselves, we will call somebody who we think can help them. And we have some very wonderful mentors who are veterans themselves that have actually gone out to find participants who we are very worried about at the time. So in terms of training, we have an OT specific course that's called Working with Farmers and Ranchers with Disabilities. While it's OT focused, I think it's helpful for anyone who is in healthcare but doesn't necessarily have any experience with agriculture. In the training, we cover some of the common values and cultural beliefs that exist in the farming and ranching community. And we also talk about how some of those beliefs can impact mental health. We also have a new training program for our mentors in the program called the Mentor Training Program. And as part of that program, we require them to go through QPR. It's actually the one that AgriSafe offers since it's specifically geared for farmers and farm families. And that way, if we do have a participant who's having a mental health crisis or need some help, our mentors have the tools that they need. And it's easier, our mentors form connections with them, sometimes that are stronger than like I have as an instructor, because most of my communication with the participant is through either email or over the phone. So having our mentors trained gives us some more boots on the ground to be able to help our participants. And something else that I've done with our mentors is done some presentations on understanding cognitive disabilities and limitations. While mental health is not necessarily a cognitive disability, a lot of times cognitive disabilities, because they're not physical and can't be seen, people don't realize what's going on. So that can be very isolating for individuals and can cause them to have depression or anxiety. So I've been working to try to educate our mentors about some of those limitations and disabilities, so they have a better understanding of where their participants are coming from. And then we're recently awarded the next cycle of the AgrAbility grant. And in this, we are actually going to be partnering with the AgriStress Network, which I am super excited about. And so one of the things that we're going to be working on is developing a mental health crisis planning tool and protocol. And the reason that I'm most excited about that is I go through and I screen our participants based on their responses to the quality of life survey. But where I don't have a degree in mental health counseling, it's really just taking my best informed clinical decision making on who we should be reaching out to. But I think having this protocol and planning tool will really help us provide the best resources possible. We are also working on developing mental health peer support groups. So these will be informal groups that people can elect to participate in, where they can just come together and talk with people who understand maybe what they're going through or what their background is. So this will be open to our veterans and our non-veteran population. And sort of as we have participants join, we can modify what the groups look like and who to include in each group. And we also have all of our staff trained in mental health first aid. And as part of this new grant, we are going to be having them trained as instructors so that they'll be able to go out and teach mental health first aid to providers in our community, as well as extension agents, since those are really the boots on the ground in the rural areas of Texas. And since Texas is such a big state, having people all over the state really helps us, since we aren't necessarily able to go and connect with people who are, we're in central Texas. So if they're in southern Texas or in eastern Texas, it's a lot harder for us to physically go and connect with people. So having boots on the ground in those areas will be really helpful. And that's kind of just an overview of what we're doing with Texas AgrAbility and Battleground to Breaking Ground. Here's my contact information if you have any questions or want to learn more about our programs.
All right, Faye. We've had two firsts today. So Faye is our first speaker concerning veteran programs. So we are doing very well today. We do have a question, and I have the same one. So you talked about some of the veterans will get like 3 to 6 free vouchers or visits. Mm-hmm. If they don't have any kind of health coverage, where do you refer them after that? Like what happens so that they continue getting their care?
Sure. So like I said, if they need additional visits while in our program, we work to have those visits covered. But then I will refer them to Headstrong and Give an Hour, since those are free resources. They do not charge for those resources, and they get them set up with a counselor, preferably in their area. But other than that, that's kind of all we have right now. Most of our veterans do work with the VA, and the VA does also offer services for them.
Oh, that's great. Amanda kind of answered that question in the chat. She said that they are trying to introduce options for telehealth in their free clinics that their counseling and nursing programs offer through the university. So that's kind of her answer on that that front. So I know you put all your contact information up on that slide, but could you put that in the chat too for anybody who wants it ASAP before we get that recording out? Yeah, and anybody can feel free to unmute and ask Faye any questions, or you can put them in the chat if you're not able to speak. Yeah, our veterans have really become a big part of our farming community. So I know most of us try to cover their care as well. Oh, and also your project, the I forget what it's called, something to battlegrounds.
Battleground to breaking ground.
To breaking ground, yes. So do you guys have a website where they can get more information on that as well?
Yes. So that website, even though it says Texas AgrAbility,
Oh, okay.
because we are sister programs, they really started under AgrAbility, but we've kind of branched out. You can find information for both of those programs at that website.
That is perfect. That is absolutely perfect. All right. It is straight up 11 o'clock. So if we don't have any more questions, we'll be sure to go ahead and send out their contact information with our YouTube recording. And I think we had a great AgriStress meeting today with lots of information. So hopefully everybody will be reaching out.
Thank you so much.
All right. Thank you, everyone.